Can a spinal fusion be done in an outpatient setting? What about a disc replacement? Can that be done in an outpatient setting? In this video, I'm going to discuss what inpatient versus outpatient is, some of the perceived advantages, what the insurance companies are saying, as well as what surgeries I typically do in an outpatient setting from the neck to the lower back. Stay tuned. So let's first talk about what outpatient surgery is. In short, it's a terminology that the insurance companies use. It pretty much means you either went home that day from the surgery, or if you did spend the night in the facility, you didn't get officially admitted and you weren't an inpatient admission order. That's more of an insurance nuance and insurance term in terms of having a inpatient stay. But in general, what most spine surgeons are referring to is surgery that's done that day and you go home that day. Now, technically you could stay overnight and still be an outpatient, but for the purposes of this video, I'm just going to talk about same day surgery, patients that have surgery that day, that morning, and go home later that day. Also in this video, I'm going to break it down into cervical, mid-back, and lower back. So the key thing about inpatient versus outpatient surgeries is first understanding insurance companies are actually pushing more and more spine surgeons to do outpatient surgery, because in short, it saves the insurance companies money. They don't have to pay for the overnight stay, medications, staffing, things associated with an inpatient stay at a hospital. And that's usually a good thing. We're all in favor of lowering healthcare prices, but it does become a little egregious sometimes when I have to take time out of my clinic or out of my surgery day to talk to an insurance company on the phone, and I have to advocate for my patient that I want them to have an inpatient stay. I want them to stay a couple nights in the hospital because they're having a major surgery. And sometimes certain insurance companies make me get on the phone and discuss why, if I'm doing a surgery where I'm going through the belly and putting a cage in through the front and putting screws in through the back, a very major surgery, I have to justify why that's an inpatient stay and why I don't just send the patient home the next day all the time. So a little not germane to this entire video, but it is unfortunate that healthcare is sometimes dictating how surgeons need to act. That's a whole different discussion. The thing I want to talk about first are the surgeries that I do as an outpatient. So one of the surgeries I do as an outpatient is a cervical disc replacement. That's where the spine surgeon will make a small incision about this big off to the side of the neck. They'll dissect through the 3 fascial planes, get to the front of the neck, and then they'll expose the area that has the soft disc herniation, the compressed nerve, and they'll place one of several different FDA-approved implant devices. These are motion-sparing devices, and the key advantages of disc replacements, disc arthroplasties, especially in the neck, is not necessarily the range of motion that's maintained, but it's the decreased rate of adjacent segment disease. These are great surgeries to be done in an outpatient setting. These are surgeries that you can do in a surgery center, and if certain protocols are met, and if the patient is healthy enough, they can go home that day. In general, if a patient is getting a disc replacement, they're usually younger, they're usually more active, it's usually a soft disc herniation, not a bone spur, and usually that means that they're a young patient and they'd qualify to go home earlier that day anyway. Another surgery I do all the time, and it is still the gold standard for most neck surgeries, is a cervical disc fusion, also known as an ACDF, for anterior cervical discectomy and fusion. This is a model of a 2-level fusion. When I do 1-level fusions, sometimes 2-level fusions, if I do them early enough in the morning, I will allow my patient to go home that day. Yes, there are other surgeons that maybe do 3 levels and let their patient goes home that day. In my hands, I usually let 1 levels go home that day, sometimes 2 levels depending on the patient and the type of surgery. At most, I make my patient stay overnight. But a 2-level cervical fusion, that's where we go through the front of the neck, through the 3 fascial planes, find the arthritis in the neck, open up that area, put that spacer in there. That's another surgery with excellent clinical outcomes, short-term, mid-term, and long-term, to fix issues in the neck such as a spinal cord compression or a pinched nerve. Yet another surgery I let my patients go home that day is something called a posterior cervical foraminotomy. Those are a lot of big words, so let's break it down. Posterior is back of the neck as opposed to anterior. Cervical is neck, so I guess posterior is actually just back. So cervical is neck, And then foraminotomy is a fancy medical word when you're making a hole in a bone to open the foramen. So it's an opening of the tunnel of the foramen. What the foramen are where these nerve tunnels are coming out. Different disc herniations, bone spurs could pinch these nerves, and that causes pain. Many times that can be treated with either a disc replacement, an ACDF, a one-level fusion, or in certain pathologies, a cervical foraminotomy, a pilot hole in the back to open up that bone spur, to open up that nerve tunnel. That's a great surgery also. I'd let my patients go home that day with just a soft collar for a couple days after. A surgery that I would not recommend as an outpatient in my hands, but other providers might do outpatient, is something called a cervical corpectomy. That's where through the front of the neck, you have to take out an entire bone right here. You use a tool that removes the column of this bone, and you put a big cage or a big spacer that fills this area, and usually a plate over the front. Some people might do those outpatient. In my hands, I don't do those outpatient. I usually keep the patient overnight or maybe an additional day to monitor swelling, dysphagia, also post-op hematomas. But as we get better and better technology and better outpatient standards, maybe that's something that we're going to be doing more as an outpatient surgery. So I look forward to that surgery being outpatient, although it's not an extremely common surgery compared to those other ones I just mentioned. Another surgery that could be done outpatient is an ALIF surgery, anterior lumbar interbody fusion. That's where the surgeon, usually in assistance with a vascular surgeon or a general surgeon, will make a small incision under the belly button, expose the area of the lumbar spine, and put one of these very high-tech spacers into that spot. This is a fusion. It's a one-level fusion through the front to fix certain conditions of the spine where you have pinched nerves and loss of alignment. That's a surgery I very rarely do as an outpatient. You could, if you're just going through the front, do that as an outpatient, but it's not extremely typical for me to do that as an outpatient. Usually, I keep my patients overnight and send them home the next day. In addition to that surgery, what's more common is not just doing that through the front, but also in the back part of the spine, the posterior part, doing something called a posterior spinal fusion. And that's where, through different technologies, a spine surgeon will place these pedicle screws and in a rod that connects them to provide additional 360-degree stability of this lower level. When I do that surgery, I usually use CT navigation that provides a better accuracy for the placement of these pedicle screws. And it's not just these two, it's a total of 4, one on the left, one on the right, and then if I'm doing L5-S1, be 2 into L5, 2 into S1 with the rod connecting them. I also use a navigated burr to decorticate the facets, the joints, as well as to lay bone graft down posteriorly for a 360-degree fusion. From a spine surgery standpoint, putting the cage in the front and the screws in the back, I usually keep my patients overnight, 1 or 2 nights. Another type of outpatient surgery I do all the time is something called a microdiscectomy. It's similar to that posterior cervical foraminotomy I mentioned before, where on the back part of the spine, a spine surgeon will make a small incision, maybe the size of my thumbnail. I dilate through the muscle tissues. I open up the muscle tissues just around this one point on the spine. I use a small ultrasonic device or a 3mm burr to make a little pilot hole in the bone. If it's at L5-S1, I usually don't have to take any bone, and then I can get into that area and remove the disc herniation or the thickened tissue that's squeezing your nerve, causing the numbness and pain. That is something I extremely typically let my patients go home that day. Now, there are definitely certain scenarios where I have an older patient with heart disease, multiple medical comorbidities, being older, diabetic, having different heart surgeries in the past. Those are the patients I usually do keep overnight just as an extra level of care to support them, and that's a case-by-case basis. Another type of surgery I do all the time as an outpatient surgery is something called a posterior lumbar laminectomy. That's something through a small incision. I usually say about the size of a credit card. I make an incision. I do a sub-periosteal dissection of the muscle layers that I then close back up at the end of the case. And I use an ultrasonic bone scalpel. That's a sharp tool that doesn't cut tissue. It kind of vibrates an extremely high frequency to melt bone. And by doing that, I can take out the arthritic piece of bone, and then I can get to the arthritic tissues in the spine. By doing that, I open the spinal canal, I make this area wider, and I can access the spine. The techniques I use and other spine surgeons use also, because that's how we're all taught these days, does not cause underlying instability. We do not violate the facets inappropriately or take too much of something called the pars. Therefore, we don't create instability when done the correct way. Another surgery I do all the time outpatient is something called a kyphoplasty. That's where I use a tiny little incision in the back. I put a needle through the bone, and in the part of the bone that's collapsed, usually from osteoporosis, I could put in a balloon that opens up that area and backfill it with cement. A kyphoplasty is an extraordinarily common outpatient spine surgery that patients do great from osteoporotic fractures that have failed conservative treatment options. In terms of recovery after an outpatient surgery, most of my recoveries are all pretty darn similar depending on what the surgery was, whether it was in the neck or the lumbar spine. I let my patients go home that day or the next day on certain medical comorbidities that I mentioned earlier. When they have a bandage on, I want them to change that bandage every single day, take the bandage off, shower, soap and water, no special creams, and once they're out of the shower and it's all dry, place a new bandage, 4x4 and some medical tape over that area. And I like my patients changing their bandages every day for the first couple weeks. Additionally, in 99.9% of my cases, I use a special type of suture or stitch, just like the plastic surgeons use, and it's absorbable. It goes under the skin and the patient never sees it. So there's never a time period where the patient needs staples out or nylon suture out. I'm not against it if your surgeon does that. I just like somewhat of the cosmetic aspects that could be applied in spine surgery by not using those devices. I also like the aspect of the patient not having to have their sutures removed, because that in itself is painful both for the patient and sometimes for my PA or myself when I have to take those sutures out. Another huge benefit to outpatient spine surgery is mobilization. Well, it kind of makes sense. If I'm discharging you home that day, it's probably a surgery that also allows you to get up on your feet, moving around that day. I highly encourage my patients to try not to get their heart rate up too much. Don't break a sweat, but I want you up and moving around a lot at your house, at your hotel, at your place of being. I want you up and moving around. That lessens the rate of something called pneumonia, infection in the lungs, a blood clot in the lungs, a blood clot in the legs. Those are key things that I'm worried about. It also decreases the rate of urinary tract infection. I tell my patients all the time, look, spine surgery is sometimes the easy part. It's me managing your medical complications after or your medical comorbidities before that make the spine surgery a little bit more risky. Intraoperatively, spine surgery has an extraordinarily safe track record. That's why I encourage outpatient spine surgeries on the appropriate conditions and the appropriate patients, because it allows them to minimize their risk of inpatient stay, medication issues, falls, other infections associated with hospital stays. So if I can get my patients up and moving that day, that's a key part of outpatient spine surgery. But it all kind of starts back to one, patient selection, and two, minimally invasive principles. Really the only way that outpatient spine surgery can continue to progress is spine surgeons like me progressing with minimally invasive technologies. That's smaller incisions, smaller muscle disruption, less pain, faster ambulation. At the end of the day, it's up to the spine surgeon. Unfortunately, it's a little up to the insurance companies, which I don't agree with at all, but that's just how it is until our healthcare system changes in America. And it's also up to the patient. I have a lot of patients that want to stay overnight, and I am able to offer them that ability to stay overnight and go home the next day. So I hope this video really showed you a lot about outpatient spine surgery. I get asked all the time, which spine surgeries can be done outpatient, which spine surgeries can be done inpatient.